I think that yesterday and this morning, the facilitators have done a fantastic job of painting the picture theoretically in terms of what we mean when we speak about the feminist economy and how politicized that is and how challenging it can be for people who are at the short end of the stick. Think about caring for a child or a baby and all of the work that goes into sustaining communities, sustaining households, and ensuring the livelihood of the households and communities which we live in. I'm sure that some of you are already doing this work, but how often do you realize that it's actually work, or do you take it for granted that it's just what I'm supposed to do, but it's actually work? It's just not measured in terms of economic metrics and not seen or recognized in our GDP. But if it was recognized in the GDP, it's actually predicted that it would be more than, it would bring in more into a country's GDP than manufacturing, for example. So that gives you a picture as to how essential this work is in terms of carrying society and moving society forward. And then we can look at emotional and social dimensions of labor, which are very important because we are emotional beings as people. We have care needs, and you have to be able to respond to these if you're a mother, if you're a caregiver of any sort. So this is the emotional work that goes into it. If you are rushing home after work because you need to get to your family so you can check on your child who may be called during the day or during the course of their school day and was saying that they were feeling unsettled or they were feeling bullied at school, you are doing that emotional work of going home, attending to them. Being a psychologist, you're not paid for it, but it's still that unpaid work that you're doing. And then in terms of cognitive labor is something that I realized quite a lot when I was doing my PhD research, where women would speak about how they had to plan meals, plan traveling times, arrange transport for their children. And I have to stress that the communities that I was working in were low-income communities. So we're not speaking about middle-class women who can say, oh, after work I have to drive past school and go pick up my child. We're speaking about women who would have to take 2 taxis to get to their place of work and take 2 taxis to come home, or take 2 taxis to get to their place of work, a taxi, a bus, another taxi in order to get back home. So you need to keep that in mind, that in the low-income setting, care looks extremely different because we are working with people who have minimal access to resources, and this by virtue just affects how they are able to do the work of providing care in their families. And the work of commuting, I've already spoke about, and I will stress again that it doesn't count as economic, but it's definitely work. It's just not realized or recognized as work, but it's work. And it's key that we reflect on some theoretical thinkers who have written about social reproduction. I will not speak about all of them because it would take up a lot of time, but Karl Marx speaks about reproduction. He was interested in who produces the worker. So the worker produces the commodity, but who produces the worker? So he was interested in understanding what happens before the workday and what happens afterwards, because the work that goes into you getting ready for work, waking up as early as 5 a.m. so you can be early for work, bathing, making sure you look decent, you look professional for your day at work, that's all reproduction. And it's not often seen as work, but if you have to wake up at 5 in order to be at work by 8, you've already started working. It's just not seen, it's taken for granted, but that's your day of working already has started at 5 a.m. And what happens afterwards? So having to go home, having to cook, having to ensure that your children have clean uniform, have clean clothes for the new day. You are reproducing your family, you are reproducing yourself for the new day, for the labor to continue, the labor which sustains community, which carries community and carries society. and it's the glue of society. So when we think about childcare, who would care for children if this form of work wasn't taking place? If we didn't have education and children, school children in primary school and high school didn't have to be in school for 8 hours of the day, where would they be? It's the glue of society. There's a functioning to it. You know that you'll drop your child off at school by 8, they start their day, and by the time that you end your day at work, you can go collect them, and the process starts all over again. So this is what we're speaking about when we're speaking about social reproduction. And in terms of emotional support, we've already discussed this, and the household labor, which sustains the family, the cooking, the cleaning, the washing, it's taken for granted. It's taken as women's work, but it's not women's work, it's a life skill. You shouldn't not be able to cook as a man just because you're a man. Of course, I'm aware of the fact that we come from cultural context. We're not without our socialization and our upbringing and what culture can enforce, but a lot of these things are life skills. Caring for your child is not babysitting, it's child care, it's your child. There's no way in which you're babysitting, but we often don't look at this in a way which is not gendered. We see it as women's work, and it's not women's work. We all have the propensity to care. Joan Tronto, who I'll be drawing on later on, speaks about the fact that care is not gendered. We all have the propensity and ability to care because we're humans. And when we are looking at social reproduction, some key concepts that we have to think of are dependency. And a theorist, Van Veel, speaks about dependency he breaks it up in 4 ways. He speaks about infants who require total dependency. It's often romanticized, it's socially shunned upon if a mother maybe is going through postpartum and is not able to care for her child, because as society, what we know is that how can you not want to care for your child? Why would you not want to care for your child? It's natural, it's taken as something that's innate for women to be able to do the work of caring for infants. And then we can look at physically disabled people, and these people, it's often deemed or looked at through a medical and rehabilitative lens, where people who are physically disabled require care from the hospital or from healthcare professionals. And intellectually disabled persons are often marginalized, and caring for them or their dependency is often seen in a way that it's like being a custodian. It's like being someone who's their mouthpiece, because they can't do a lot of the thinking and talking for themselves. And then refugees, this is dependency which is often politicized, it's stigmatized, and we've seen this in South Africa. We had our Minister of Health, Aaron Motsoaledi, I think it was 2018 or 2019, I stand to be corrected, but he said that our foreign nationals were the people who were taking away health care from South Africans. And you can see how politicized someone's refugee status can be, how caring for people who are in need of care can be problematicized based on their nationality and what they need from the country where they are seeking refuge. And another concept which is key in talking about dependency and interdependency is Ubuntu. Interdependency is interlinked with Ubuntu. And Ubuntu is such a crucial concept. It came up twice yesterday with our facilitators who were presenting, and it's such a poignant principle in the manner that it was the principle which the judgments that the judges and the Constitutional Court who did away with the death penalty in 1995, States versus Makwanyana is the case that does away with the death penalty. It came from the fact that there was no humanity in taking someone's life. You are not being human by punishing someone by taking their life. So this is a concept which is key in thinking about care, interdependency, ensuring that I am because you are. Although Ubuntu it's quite vast in what we interpret it in English, that I am because you are. It's deeper than that. It's about ethics, it's about dignity, it's about care, it's about love, it's about culture, and realizing that you cannot exist in an island. No man is a one man. You need other people to exist, and you need to give value in that by being caring in a situation where care is required. And an example of this is COVID, the COVID-19 pandemic. It showed us what it's like when Ubuntu is not there. At a time where we were restricted, we were quarantined, we were encouraged to stay in our households and be alone. If you didn't live with your family, or if you didn't live with someone else in the house, you were essentially alone. Like I was living alone and essentially alone during this time. I had a friend who was sick with COVID during this time. She lived alone. She had been told at the hospital that there was no need for her to be at the hospital and that she could treat herself from home, and she had this fear of dying alone. And again, this teaches us how crucial that principle of Ubuntu is, and how interdependent we are in care. And a crisis like COVID showed the value of the principle of Ubuntu. Solidarity, togetherness, cohesion, which is needed for the functioning of society. Emile Durkheim, a sociological thinker, speaks about the fact that we are all interconnected and that we need one another to exist in society for the functioning of society. And Joan Tronto, who I've already spoke about briefly, speaks about care as an ethic. She speaks about the fact that care is not gendered. Everyone has the ability to care. It's all about how we're socialized. And she speaks about caring about, being attentive, recognizing that there's a need for care and the responsibility of responding to that need for care, caregiving, which is the direct action of giving care, and ensuring that you're competent in giving that care. I have had an opportunity to speak to older persons receiving care, complaining about their caregivers who are often family, that yes, I'm being cared for, but the quality of care, the quality of my life has deteriorated because the person who's caring for me is just doing it as a thing to just tick off their list, but their heart is not in it. They are not vested in providing care. So you have to not only recognize that there's a need for care or respond to a care, but it needs to matter, and the way in which you provide care needs to show that it matters to you. And the care receiver, the responsiveness of the care receiver. So what are they saying? Like the care receivers that I've been able to speak to, who have been sharing positive experiences or negative experiences of care or being cared for. Invisible work. We've spoken about how care happens in the private space. It's not seen, it's not valued, it's not recognized because it's happening in a private space. And yesterday you had a presentation from Prof. Benya, who writes about invisible care. She writes a very important paper about how invisible work is essential for maintaining the economic well-being of any country. And she writes in the context of mining in South Africa. I think it's so fitting to discuss this concept in the Northwest, because in Rustenburg, not too far from where we are, we have Marikana, which is a mining town. And I'm sure you may have heard of Marikana, the incident where miners were, it's called the Marikana massacre, because the miners were striking for an increase in their wages, and the state, along with the Lonmin mine, responded by firing and killing 34 miners. And this showed how crucial mining or productive work is for the economy, but also what Prof. Benye writes about in this paper is the fact that what is not seen are the women who are doing the domestic labor, who are looking after minors who are injured, who are cooking, who are reproducing the minors in order for the production work to continue. This work is not seen, it's not valued. And then we had Marugane, the incident, and again, the people who were bearing the needs for care, looking after children who had lost their fathers, lost their uncles, lost their brothers, looking after households. It was women who were doing this work, and these are the things that we need to think about when speaking about invisible work. And before I introduce the work that I've worked on, the work that I've done, I'd like to draw on Bell Hooks, who writes about feminist scholarship and ethics. Again, I'll reference Prof. Benye yesterday. She spoke about how positionality or reflexivity is not merely about doing a checkbox of I'm black, I come from a middle-class family, I'm aware of my privilege, and because of this, I'll be able to step into a low-income context or a rural area and be able to do the work because of those factors that I'm aware of. That's enough. That's reflexivity. That's my positionality. But it's the ethics of how you come into the space. If you are working in a low-income environment, a rural area or urban area or township, how are you coming into that space? You have to be aware of the beneficence of research, so not wanting to cause harm, but to do good. The need to protect your participants and ensure them that they are safe and make the research a safe and landing space for them, make them realize the fact that although the outcomes or products from the research may not be immediate, but over time, through policy, through how the work will shape policy, they have influenced some form of social change in society. And Bell Hooks speaks about how we need to position ourselves, we need to be reflexive when we're entering into a space. Who has the authoritative voice and why? Research for the longest time was seen as something that was being done to people, but people are participants. They need to be co-creators of knowledge. Your participants are not some subject. They're participants because they are actively engaging in your work and contributing to co-creating knowledge with you in order for you to be able to gain whatever it is that you're trying to do or influence with your work. The politics of care. Here I would like to draw on how care can be political. So in 2023 and 2024, I worked on a care for older persons, and we were looking at care for older persons in Southern Africa. We were focused on Malawi, Botswana, Namibia, and South Africa. And some of the challenges that older persons spoke about is being unseen in their households, being taken for granted. And this saying, it's a Zulu saying which kept coming up in interviews, ukuzala ukuzelula amathambo, which means that to give birth or to have children biologically or sociologically, because some people are social parents, is to stretch yourself and care for yourself in your old age, because the idea is that these people, the children, will be able to care for you in your old age when you are no longer able to care for yourself. But this is very politicized, and I worked in a rural site, which is in KwaZulu-Natal province here in South Africa, and an urban area, which is not too far from the rural area. So it's more peri-urban than urban. And in these places, I was able to find older persons who were able to allow me to step into their lived realities and understand what care means for them at an older age, where you have increasing needs in terms of care. And what kept coming up was kusinda nongathwele, kusinda kwehlele. This means that there's a heavy burden, there's a heavy load which comes with care work. There's a heavy load in providing care and in receiving care as well. And then looking at how politicized this is, older persons spoke about disrespect in their households, so not feeling seen in their household, although culture tells us that out of ubuntu, out of respect, out of value, you're supposed to value your older person because they are seen as the custodian of culture. They are seen as the custodian of a family's well-being. But the older persons that I spoke to at a community forum that we had, where we invited older persons and we also had caregivers in the same space to discuss what challenges they are facing, what assistance is needed in order to provide adequate care for older persons. But the older persons spoke about feeling disrespected, not feeling seen in their households, and the abuse of older persons. They kept saying, where's the respect? We are abused. Some children just take money from us. So there was physical abuse and financial abuse, which was reported upon, and emotional abuse as well. And in terms of, and migration on the care for older persons as well. Older persons spoke about the fact that they have children, but those children are not able to provide care for them because they have migrated in order to be able to work, in order to be able to send money home. But for the older persons who spoke at that forum, they were saying that I understand that my child has to work, but what does that mean when no one is here to provide care for me? And the caregivers that I spoke to spoke about not feeling valued, not feeling seen. And I'd like to read some quotes for you, which I think capture these experiences. So in this family, it was very interesting because the older person seemed to recognize that his daughter was providing care, that his daughter had sacrificed a lot in order to be able to provide care for him. He said, my daughter does everything for me. Even with getting the crutches, she was the one who organized that. My wife passed away in 2014. She passed away from complications with diabetes. The person who was my wife's caregiver was my daughter. She made sure that she was clean, that she was comfortable, that she went to the clinic for checkups and to the hospital when needed. It was the sacrificial kind of love and caregiving. But his daughter had a different view. She felt taken for granted. She felt unseen. She broke down and shared to me how she had given up on aspirations and dreams she had. She had wanted to become a truck driver, but it's a dream that she had to let go of in order to be able to provide care for her mom, who was alive at the time, and later on her father, who then had care needs. She said that, I told my father that I had found a job, that I was going to work as a maid. He said nothing, but I left and he was not happy. He told members of our congregation, this is at church because the father was a pastor, that I was being belligerent, that I was not listening to him. I decided to come back. I am here now. I am taking care of him. I live in his house, and that is the end of things for me. I cannot be able to recognize or realize any aspirations that I have for myself. Yes, I did not complete my education, but if I wasn't doing this work of caregiving, I would be better placed to be able to at least better my life. But currently, I'm just dependent on whatever money he gives me and my brother, who is not always kind towards me, as he takes the care work that I do for granted. In the urban side, caregivers shared giving up on their dreams in order to be able to do the work of caregiving. A participant I spoke to said she was a caregiver for her grandmother, and she said, I actually did get a job, and you know how hard it is to get a job in South Africa. I had to let go of the job, however, because it was far, and I was worried about not being able to look after my grandmother. I know that no one else would be able to care for my grandmother in the way that she needed to. I also want to find a caregiver who's able to care for my grandmother properly before I can be able to take any job which takes me afar or which requires me to have to move. And then which I found interesting as well was a caregiver who said that she gave up on her love life because Nancy Falbray, who's a feminist economic scholar, also writes about whether we do care for money or love. And here we see someone giving up on their love life in order to be able to do the care work and love work of caring for her mother. She said, I gave up on my love life. My boyfriend was from another province. I have not been able to look for work, so I'm just here caring for my mother. I am getting old now. I am 50 years old, and the chances of getting a job are slim. So this is it for me, I guess. And another caregiver in the urban site said, I am looking for work, but in the meantime, I am a full-time caregiver for my mother. But although doing this work of caring, they are not being paid, they are not being compensated, it's not being realized as care work. It's taken for granted as something that you are just supposed to do, because if you don't care for your mother, who will care for your mother? And the person, what we need to realize is that the care conversation needs to be broadened. It's not just supposed to be between the carers and care receiver. We need to rope in government into this. We need to rope in traditional leaders in the rural communities. They have to understand what is going on in terms of care. The state is also very integral in providing care for older persons. Providing cash transfers alone is not sufficient, and we realize this in doing this work. The work of Fakir and Koch in 2009 writes or speaks about the African household as a site for the crisis of social reproduction, and African women as the shock absorbers of this crisis. And I think it's such a fitting way, because the people who really are the shock absorbers of the crisis of social reproduction are African women who are doing this work with minimal resources. They are not middle class, so they don't have that agency in terms of being able to outsource care. They are doing all of the work. And speaking about the state stepping in, we know that South Africa has a very generous cash transfer system. And as part of providing care for older persons, the state realizes that there is a care need, which is why we have a grant and aid. But a lot of people don't know the grant and aid, and the grant and aid is not necessarily promoted by the state. I guess it wouldn't be sustainable for every older person needing care to receive the grant and aid. And part of our sub-project, as part of the work of looking at the care for older persons, we had a sub-project which was about getting people who need the grant and aid aware of the grant and aid, applying for the grant and aid, and seeing whether they'll be able to receive the grant and aid or not. But what we quickly realized was that it was all over the place. So if you look at the slide, it's scattered, and I've done that intentionally because we also didn't have a clear pathway as to how you apply for the grant and aid. Neither did the older persons that we were working with. I spoke to a SASSA official about the process of applying for the grant and aid, and he was very nonchalant about it, and he said that, well, I'm not working on the ground, so I don't know how the system actually works. And information in terms of what you have to do to apply, we realized that you need a referral form, and you have to then fill out the referral form and apply. You have to get assessed by a SASSA official doctor. So you can't just go to any doctor and require the doctor to fill in the form for you and sign it off, and that certifies that you need care and that you can qualify for the grant and aid, which bumps up the older person's grant that you are already getting. It has to come from a SASSA doctor. and SASSA doctors, you have to be referred by SASSA where you have to go. Now, the implications of this is the fact that if you are working in a rural area, if you're working in an urban site even, you are working with people who are in low-income environments who don't have a lot of resources, and you have to do back and forth trips to be able to complete forms and to be referred and to be able to move along the process of your application for a grant in aid. The participants that we worked with spoke about how they were told to come back tomorrow because this is not the day for grant in aid. They spoke about how they needed money and transport to get to the clinic, to get to SASSA. They spoke about how some of them were not doing this just using public transport, but had to hire private transport because they couldn't walk or had ailments in terms of walking, so they had to hire private transport, which is very expensive in a rural setting because hiring someone's transport means that for the whole day they have to accompany you to SASSA, to the clinic, or wherever you are going. And it's a cost that households in the setting can't afford to bear. But with doing this work, we were able to at least assist the families where we realized that there was a need to apply for this grant in aid. And some of them did get it. I had a participant call me last week. The process started last October, but she was able to call last week and said that I finally was able to qualify for the grant in aid. It took a very long time, but I've been able to qualify for it, and it makes a significant difference. That amount of money makes a significant difference for a family which is living below the poverty line. And drawing from work or research that I did during my postdoc, this focused more on healthcare, and I'd like to focus here on how healthcare can be politicized. So caregiver, care receiver dynamics are very political in the family. It's the work of providing care and what this means for families which are stretched thin with minimal resources. We worked in Gugulethu. This is a township which is in Cape Town. It's on the outskirts of Cape Town. It's 15 kilometers away from Cape Town, but you can realize the divide between Gugulethu and Cape Town and the more affluent areas of Cape Town. And we also did work in Mulungula, which is a rural area in the Eastern Cape. And in this setting, it was very hard, even for us as researchers, because of just the terrain of the rural area. And I was thinking to myself, whilst we were walking up hills, crossing rivers, I thought to myself, how does someone who requires care or who is in need of care do this work of commuting when they are not well in terms of their health? And the care receiver approach, which I realized in the interviews that we were conducting, was that care receivers had a very positive outlook to the work of receiving care, the work of being cared for. And just to provide some context as well, these care receivers that we were working with were care receivers in healthcare, so in clinics. It had to be primary healthcare, and we were working with care receivers who are often older, who lived with non-communicable diseases and HIV. So we wanted to see how care receivers having to manage these conditions were coping. And what care receivers shared was the fact that they had to have an optimistic ideal, an optimistic approach to receiving care. They spoke about challenges within the healthcare system, not feeling seen in the healthcare system, feeling disrespected by healthcare providers, but staying above that because they realized that the attitude had to be positive in order for them to be receiving care and be compliant to the medication that they had to receive from the clinics. And the strategies of coping from the poor attitudes, from healthcare providers, again, had to be having that optimistic approach that it's not about what they say, whether they shout at me in the event that I default from my medication or if I don't come to the clinic on time, but I have to do this for my well-being, for the well-being of my family, and ensuring that I stay alive, especially for those who are living with HIV and realizing what not complying to their medication or ART can do for their health. And we can look at the caregivers' approach, and they felt a duty to care. Again, in this setting, they spoke about not feeling seen, not feeling recognized, having made a lot of sacrifice in order to be able to care for the care receiver, but just having to do it and sacrifice on dreams and ideals that they personally have for themselves, of wanting to start their own families, of wanting to pursue work, but realizing that I cannot do this because I have to have that spirit of ubuntu and care for my mother or father or uncle who's older and is vulnerable and needs care. And then we can also look at carers and caregivers' need of information. So a lot of the caregivers that we spoke to and carers spoke about wanting useful information to help them cope and manage their conditions. They felt like at the clinic it was not biopsychosocial, which means that you have to look at the biological aspect, the psychology aspect, and the social context of where the patient is coming from. So it was not inclusive, it was very biomedical, and it meant that you just got your diagnosis, you received your medication, and that was it. But there was no further information in terms of what the condition actually is, what is actually needed to eat well, to better manage this condition. And the participants that we spoke to spoke about just requiring more support from the healthcare space. And I'd like to also use an example from KwaZulu-Natal, which looks at childcare. This example stems from my PhD, and I was interviewing low-income employed mothers and looking at childcare and how childcare needed to be better supported. And what the mothers were saying was the fact that I am aware of the fact that the conditions in the creche or the conditions in the early childhood development center were not adequate, but because of my income, because of my low meager income, this is all I can afford. And I had the opportunity to observe the ECDs and creches, and indeed they were not of good quality, but the facilitators in the facility did try their best with the minimal resources that they had. And these images are just to paint a bit of a picture for you in terms of what childcare looks like in a low-income setting in KwaZulu-Natal. Again, we are not looking at middle-class mothers who can afford to pay for childcare in a more affluent area. These are mothers who are working with very minimal resources, and this is just for you to have a glimpse or glance as to what it looks like. And yeah, again, it's the childcare as a crisis in South Africa, and women as the shock absorbers of that crisis, because it's mothers who are African working class mothers who have to bear the burden of inadequate childcare. And we've had 30 plus years since democracy in South Africa, but there's still a considerable difference between the childcare which occurs in more affluent area and low-income areas, and some change has to happen. Merely speaking about the fact that basic education needs more funding, needs more attention from the state does not suffice. We need action. And we have COVID, which shows us the consequences of the poor response that the state has had to ECD care, to creches, and the attention that this needs. So into 5 weeks into lockdown, Minister Lindy Wezulu was asked, what is the state of childcare? What are you saying about ECDs? What's going on there? What's going to happen to the children? And she said, oh, we have not given it full consideration, and that's her quote exactly. And I won't go into the paper that me and my colleague were able to write around this, and going into the field and interviewing mothers who were requiring care during this time, who were stretched thin, some of them being essential workers, so who didn't have the privilege to be able to quarantine and work from home. They were cashiers, they had to continue going to work, and what this meant for them. For the interest of time, I won't go into the detail of this, but what COVID did is put like a light in terms of the focus which is still needed in the state's response to childcare, paying attention to childcare, and making sure that it's adequate, it's prioritized, and the care which is provided for Black children is valued, because it's Black children who suffered the most during this time. And what COVID did as well was show us the workload which happened with mothers losing jobs. They had to reconfigure their budgets. This mother was able to speak about the fact that she was no longer, because of a pay cut that she got due to COVID, she was no longer able to buy her child all of the things that she previously had been able to. And this speaks to how a crisis impacts childcare, a crisis impacts the state of social reproduction which is happening in households. And at the back end of COVID, just when South Africa thought we have this under control, we have this managed, we had floods. In KwaZulu-Natal was hit quite hard with floods. Some bodies still haven't been found till today. We had floods again at the beginning of this year, and again it was women who were at the forefront of providing care, of realizing that there was a need for caring, not only for their families, but other members of the community who were left stranded, who didn't have the resources to be able to rebuild due to the damage which was done by floods, and the people who were carrying the work, who were carrying this burden of care in responding to the crisis of social reproduction were women. And I'd like to move on more to work that I'm doing currently. And this work is focused on adolescent health, and we are working in Umlazi. Umlazi is the second largest township in South Africa. It's a low-income area, and that's not to take away from the fact that some citizens or residents of Umlazi have been able to achieve upward mobility, although they are still living in Umlazi. But majority of Umlazi is still marred by poverty, it's marred by underservicing, and in this setting we are working with adolescents who are facing challenges, and we're looking at socio-demographics, we're looking at health awareness and behaviors, we're looking at mental health, we're looking at substance use and sexual reproductive health, which is what I'd like to focus on for the purposes of this presentation, because it speaks to social reproduction and how SRH is an issue of care which needs to be done better in the South African context when we are thinking about the early age of sexual debut, which occurs pregnancy and pregnancy outcomes. And this is, I won't go into detail, but this is to provide you with a look as to the participants who have participated, the adolescents who have participated in our study, and you can see that majority of them are women and majority of them are still in school. And then here I would like to focus on the experience with pregnancy. So And what jarred me was looking at this data. This is quantitative data, and the data, the percentage of the 1% of men who said, the question is, have you ever made someone pregnant? And 1% said, I do not know. And for me, with my social reproduction hat on, I was just like, how many women have the privilege to not know, which means that the work of caring for children is seen as women's work. The work of dealing with outcomes which stem from pregnancy is seen as women's work, which calls for boys, young men, to be drawn into the conversation about sexual reproductive health as well. And we have to be aware of the fact that we don't all have the same access to reproductive health, and this needs attention in the context of South Africa. We need to be aware of youth and adolescents, SRH, and what culture imposes and expectations of culture, and how this weight is put on young girls and young women to not fall pregnant, to be abstinent. Why is it not a focus on males or boys to ensure that they abstain, that they ensure that they don't get someone pregnant? So we can't put all this work and load of SRH on girls and women alone. And a condition that I'd like to speak to, which happens a lot in the rural setting, is female genital stomatitis. And this is a tropical disease which you get from unclean or infected water, which affects your reproductive organs and reproductive health. And it's often marred with stigma, with people thinking that you are sleeping around, that you are not caring for your genital area. But this is an issue of access. If there was clean water, if we all had access to clean water, we wouldn't be dealing with such conditions for young girls and young women in the rural setting. And community health workers are majority female, and they carry the load of ensuring that they get contraception to the adolescents who require it, and other women in communities as well. They are often female, and they work very, very large areas alone, so they need support. They need to be supported. The community health workers I've had the opportunity to speak to in KwaZulu-Natal spoke about how she feels overwhelmed, she feels stressed. She's a counselor, she's a psychologist, she's a pharmacist in terms of having to dispense medication or pills or whatever's needed from the community. So there's so much that's required of her, and she's doing this work alone with minimal to next to no support. We've already spoken about these areas, about how girls are seen as caregivers, boys as autonomous actors, and families as care units are not utilized enough. We had 2 weeks ago, we had a focus group where we were speaking to girls and boys of different age groups to understand what they understand about SRH. And what came up was the fact that the conversation was not happening within the household. So the family needs to be roped into the conversation of SRH. It's not supposed to be seen as this taboo topic that no one wants to talk about, that no one wants to touch. We all need to be active engagers in speaking about SRH for the well-being of girls, not only girls, but boys as well. And the feminist political economy helps us to critique how SRHR, including the R for rights, is shaped by the structural neglect. So because it's been structurally neglected, the response from healthcare, the response from families has not been sufficiently supporting adolescents, and this needs attention. And this theoretical framework helps us to think about the attention which is required, the resources that are required and the interventions which are required. And policy implications is just the need for recognition, the need to invest in community-led SRH initiatives. So they need to be context-specific. They need to speak to the context. A context in the Northwest won't be the same as the context in KZN. And in developing these initiatives, this needs to be a focal area that's kept in mind, that we need to be specific to each area that we are targeting or working towards SRHR, which South Africa and the Department of Health has strong attention for this portfolio, but what's happening on the ground is not showing that legislation or the state's interest in making sure that substantial and adequate information is being given to caregivers and adolescents when it comes to SRH. Informed recommendations, you can have a look at this in your own time, and what's also key is looking at the care diamond and the fact that we have the household, which is responsible for care, we have the state, which is responsible for care, not only in the form of providing social transfers, but the state is important because it can be a decision maker when it comes to care provision, which means that it has the ability to put strain on the market and families and not-for-profit organizations to ensure that care work is being provided in the way that communities needed to be provided to speak to them and speak to their context. And these are some care ideals that we need to stop looking at care as women's work. We all have the ability to care, and economic justice and fair compensation. And paid labor, let's say in the form of domestic labor, is often not compensated adequately. And in the context where I've been able to conduct interviews, the domestic workers that I've spoken to spoke about the fact that they were not being compensated adequately or in the way that our labor laws require. But when I spoke to the employers said that this is not exploitation in the Marxist form. It's just because I can't afford anything else, but I need the caregiver, I need the service. So you land between a rock and a hard place, because in a country like South Africa, where we have a very high unemployment rate, you have people willing to take the job and not be paid adequately, and you have people willing to employ people and not apply or subscribe to labor laws. And policy reform, we've already spoken about how policy reform needs to be done or what it can look like, and education and training. On the study on the care for older persons, we had participants who spoke about the fact that I've been out of productive work for 10 years because I've been providing care for my mother. The work that I've been doing is care provision for my mother. But and now I don't know how I can have that work recognized. Is there some recommendation letter that your organization can write to validate the skill set that I have for the 10 years that I've been providing care for my mother? And the truth is, the person providing the care never left the economy. They never stopped working. It's just that this form of work is unseen and unrecognized. And sustainable and equitable systems, we need to be aware of the fact that care ideals or care economy ideals don't look the same for everyone. Intersectionality needs to be kept in mind about the fact that our race, our class, impacts how where we place, where we land when we speak about the care economy. Thank you very much.